right, thank you very much, everybody, for being here. Well, the rotator cuff, you're probably all aware of the four tendons combining the joint, which are responsible for our motion. And we know that as long as the age going on, there are more chances to have a rotator cuff tear, and some of those tears are irreparable. So, how we define the irreparable rotator cuff tear? Whether it's the size of the tendon or the tear, whether the patient age or condition, whether it's the muscle condition. We know that some of the tear has fatty degeneration and fatty atrophy, which permit us to repair the tears. Whether it's the bone condition, osteoporotic patient, if you try to put some anchors in the bone, they will pull out and the surgery will fail. Whether the chronicity of the tear, if it's a long sustaining tear or acute tear, that will give us the chance to repair it, or the surgeon's skills. In theory, nearly all cuff can be repaired, but of course not all should be repaired. Baltimore declared that nearly all tear can be repaired with a proper technique. Goutelier, which is the classification for fatty degeneration, the changes within the muscles, he declared that only if it's 100% atrophy of the muscle, then it should be not only reason to attempt to repair. Others would say that even if 50% of the muscle already had fatty degeneration, don't repair the tendon. So, let's presume we have an irreparable tear. We all agree that it's irreparable, and we decide what to do next. What we can do, we can treat it non-surgically, like physiotherapy, anti-inflammatory drugs, steroids, analgesics, and skillful neglect. Or we can try to do some surgery. Debridement, arthroscopy debridement, just clean up the synovitis, long head of biceps tenotomy. We know that the long head of biceps can cause a lot of pain. Try to attempt partial repair, patches, deltoid flap, and other options which I'm going to describe in a minute. So let's talk about debridement. The results of debridement are not bad at all. In this study, all patients, or nearly 80% of the patients, were happy. In this study from 2008 on arthroscopy, the ASCH, which is kind of a score of the shoulder function, improved from 24 to 69 out of 100. And Pascal Boileau, which is a well-known orthopedic surgeon, declared that 78% of all these debrided patients were perfect or were pleased. He said that pseudo-paralysis, which means they cannot lift their arm, not because of neurological damage, because of rotator cuff tear, and degenerative joint disease are the only contraindication for this surgery. What about partial repair? Stephen Burkhardt from Texas published many cases of partial repair, as well as Badi Savoie, and they say that if you compare the partial repair to a complete repair, the results are quite similar, so we can be quite satisfied with doing only a partial repair. Patches. Patches are actually augmentation. They could be either autograft, allograft, xenograft, or synthetic materials. These tendon substitutes are limited in availability, and we know there's a high percentage rate of complication as well as graft failure. The complete healing of those patches is rarely achieved. This is Scott Rodeo, 2007, did many research on those patches. And to define the problem, we know that we have a hole that we need to fill in those rotator cuff tear, and we have bad tissue that we need to augment. The extracellular matrix, these patches, could be either defined by the source, whether it's a dermis, small intestine, submucosa, the species of the donor, whether it's human, porcine, or bovine, the donor age, whether it's a fetal or adult, and the processing that this material has been gone through. This is a very nice study comparing 7 extracellular matrix patches available on the market, and they found that the human tenocytes react most favorably to dermal patches, okay, unlike the intestine mucosa or the other ones. What about the synthetic? They're not very popular on the market. However, this study, which was only on 10 cases, showed that MRI at 12 months, 1 year after surgery, healing was 90%, and no adverse event associated with the patches. Again, they are not very successful on the other publication. Deltoid flap also can be an option. Tendon transfer, very, very difficult surgery with a high percentage of complication, and it's beneficial only to a very narrow population. Reverse total shoulder gain more and more popularity. That's actually a total shoulder replacement. However, it's a big surgery, and if you can avoid big surgery, always try to avoid them. And now there is a new solution. It's called the in-space. As you can see here, it's actually a balloon inserted in the subacromial space over here. So it's a biodegradable spacer made out of Vicryl, which we use on sutures. Already more than 6,000 cases all over and more than 5 years of follow-up. As you can see here, that's the arthroscopy. We look from the back. On the left, you will be able to see the glenoid over here. That's the humeral head. This is the cuff. This is the cuff that's supposed to be over there. You try to pull it, it doesn't move. It's a chronic tear. This is a basically irreparable cuff tear. You cannot suture it back to where it's supposed to be. At that stage, we measure the length of the tear in order to know what the size of the in-space balloon we're gonna put inside. This is the balloon, how it comes folded. Okay, it has to be in the right direction and the right length. And the next step, we're going to inflate it with saline. So now we can actually see through the balloon. This is the cork, which will seal the balloon at the end of the procedure. This is the humeral head over here. This is the space between the humeral head and the glenoid. And if we look from the top, the balloon is already inflated. It's stable in place. We can move the arm back and forth, and the balloon stays in place. That's the joint. This is the glenoid. A little bit of science. There are many studies conducted at the moment. Laurent Lafont from France, guys from Italy, Gervasi, and other guys from Italy, and some of them from Slovenia, Switzerland, UK, and Germany, all doing the studies at the moment. However, there are already 2 studies that have been published. The one from Slovenia, this is the first study that was conducted. The objective of this study was to examine the safety and the performance of the in-space, and the inclusion criteria were massive tear or irreparable tear that failed to conservative treatment. It was a prospective study, started in 2008, 24 subjects, 20 were irreparable, 2 were partial tear that haven't been repaired, and 2 massive rotator cuff tear. From safety-wise, the device has no related adverse effect. Ultrasound done at 3 months after surgery, no significant implant dislocation, which means this balloon is stable in place. An MRI at 3 years shows no significant finding, no bone cyst or any other problem with the device. If we look at the result of the function of the patient after 4 years, this is the Condon score, which we're going to elaborate later on. But look, that's the beginning of the just before the surgery. That's the baseline, 34 points out of 100. At 4 years, it's 66 points, nearly twice as much. At 5 years, it stays nearly the same as 4 years. And if we look at the content of this constant score, the yellow, that's the constant score we saw before. It's made out of pain, ADL, range of motion, and power. So we can see that the ADL improves, the pain improves significantly nicely, the power stays very low, and the range of motion improves as well. So the balloon works in terms of functioning, not in terms of power. This is another study. This is a study done in Israel, a multi-center study, and the objective was the safety and efficacy of the balloon. It was one-arm, non-randomized, multi-center. We had 58 subjects in 5 clinical sites. 48 had arthroscopic surgery, the same that we saw in the movie. However, 10 cases were done by local anesthesia under fluoroscopy, which means it could be also an office procedure in a way. Again, the same constant score, a little bit better than the one we saw before, but still the same constant score and the same parameters. The power stays low, however the function and the pain improve dramatically. Serious events. Well, we had one inflammatory reaction. Bear in mind it's like a huge vicryl that we put inside the shoulder. We thought it's infection, however all the cultures were negative and probably was inflammatory reaction. This is a patient, one of our first patient. She's 74, that's before the surgery, just before. You can see the vein line here. We're talking about the right arm. She can lift her arm. And this is how it looks on the x-ray. See, that's the balloon over here in between the humeral head. Sorry for the... At 3 months, she can lift her arm with no help of the other arm. She has much less pain. And this is a minor surgery. Like if you compare it to a total shoulder replacement, there is a huge difference. This is at 1 year post-op, constant score already 79. And you can see her smiling, and she's doing that because we ask her to smile. She's actually happy. This is our ultrasound at 1 year. You can see actually if there's some tissue over here between the humeral head and the acromion. So my 5 to 6 year experience, we have plenty of questions. How does it work? We don't really know how it works because after 3-4 months it's resolving. So is it an artificial bursa? In some cases, like in this lady, when we saw the ultrasound, there is like kind of a bursa. However, in other cases, there is none. What we believe happens, that it's improved deltoid function and improved rehab by lowering pain. In a way, it's like bringing back the shoulder to a non-painful deltoid functioning massive rotator cuff tear. The same as other patients that have massive rotator cuff tear and have no pain. Is it because of the debridement of the long head of biceps? Well, we're not sure because some of the patients already had no biceps and they were still very happy with the surgery. So, our clinical indication for at the moment is irreparable rotator cuff tear. All patients that cannot have a total shoulder replacement, like patients that are too sick to have general anesthesia, or patients that are reluctant to go through a long rehabilitation and want to go back to work. So for me, the ideal patient is a patient that can lift his arm and has no pain at all, and has a lot of pain in order to reduce the pain. Of course, we don't do it on a osteoarthritic patient or patient with have infection or glenohumeral instability. So our conclusion, it's an easy procedure, relatively easy procedure. In some patients it takes as much as 10 minutes. It's relatively quick and quick rehabilitation, and the significant improve have seen in nearly 80% of our patients. Thank you very much.